All right, welcome to today's episode of Doctors Unscripted. Today we're excited to have Jason Hannon, who's the CEO of Mainstay Medical. They have a product that most people may recognize as Reactivate if they don't recognize the name Mainstay. So really excited to have you on.
Thanks for having me.
First things first, I'd love to hear a little bit about your company and how you got involved with it.
So I had run a spine implant company for years before this in the spine fusion space. And I did all the business development for 14 years of time there. Mm-hmm. And I saw this device in the early stages of development. Mm-hmm. I actually thought it was best positioned as an adjunct to spine fusion, to make spine fusion better.
Well,
I watched it.
Yeah, let's talk for a second. What is Mainstay Medical and what is Reactivate really quick? For those that haven't heard of it, let's get into that first.
So the simplest sense, we have a device that treats patients with mechanical axial back pain. So your pain is in your back, your buttocks, maybe your hips, but it's local to those areas. We use neurostimulation to rehabilitate the muscle that's the core stabilizer in your low back.
The multifidus.
Yep, the multifidus. And if many patients have back pain because that muscle's not working, so your lower joints in your spine, your lumbar spine, are unstable. Okay. If you rehabilitate the muscle, the hope is you stabilize the low back and then you heal secondarily from the sources of pain. So we don't technically treat pain.
And how long have you guys been around?
We've been around about 16 years. Research started 16 years ago.
Okay, so it's part of neuromodulation. Really, however, it's very different focus. So most neuromodulation, like in our company, we use neuromodulation a lot for non-surgical back pain, diabetic painful neuropathy. We'll see it for CRPS type 2. We see a lot of different conditions. This is really axial spine pain. And why is it so different from the other types of neuromodulation that we use?
So classically, neuromodulation is used through modulation of waveforms to block pain signals, or at least stop the recognition of pain signals. We don't treat pain in that sense. And we definitely don't treat neuropathic pain, which most forms of neuromodulation, as you know, are for. We use neurostimulation to take the place of what your central nervous system's no longer doing. And what I mean by that is the simple reality of your central nervous system sends a signal, elicits a contraction of a muscle through an electrical impulse. The muscle contracts and performs its function. In our patients, that process is not occurring as it's supposed to.
Why is that?
So the best way to describe it for most people is the analogy of your knee. If I go skiing and I tear my ACL or a meniscus, my brain will inhibit the neural drive of my quadricep. Yeah. It's a pain avoidance response. If my quadricep's not firing, my knee doesn't move. My knee doesn't move, it doesn't hurt as much. I mean, it's that simple. If you take it to the low back, the multifidus muscle is the main stabilizer of your lumbar joints. When you have an injury, which is most often a facet injury, you pick up a box the wrong way, you fall off your bike, anything that can happen, your brain inhibits the neural drive to the multifidus. The uniqueness, the whole understanding of our therapy is, unlike your quad, the multifidus is an anticipatory firing muscle. It's not a volitional muscle. It fires before you move to pre-stabilize your spine. Yeah. When that's not working, your joints move too freely, and that's the pain these patients experience.
Okay. So the intent of this, rather than blocking a pain signal, we're rehabilitating that multifidus. So how does that work specifically?
So the best way to describe this, if I would normally stand up and do this. If you reach to your lumbar spine and you feel your spinous processes, right, the bones that stick out in the back,
the bumpy parts on the back. Yeah.
Exactly, dunk, 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 right as you go down. Rest your fingers just to the side of it, and if you do that, you're on what would be your multifidus muscle. It's a deep fiber. It's a few layers in, but it's there. If you simply move your arm up and down on the other side, you'll feel the multifidus firing in a healthy spine. The research that was done decades ago finally figured out the timing of when that muscle fires. And so the simple experiment was you take a bunch of patients with low back pain and a bunch of patients with no low back pain. And you put fine wire EMG needles into the multifidus so you can measure the timing. Yep. And you're told when the light on the wall flashes, raise your arm. It's a whole experiment. If you have no back pain, the sequence is light flashes, multifidus fires, then your arm raises, right? If you have back pain, light flashes, arm raises, your muscle either fires late or not at all. Yep. Enabling then, unfortunately, in back pain patients, the segments to move unconstrained in the movement. It's why our patients experience pain doing the dishes, brushing their teeth on the sink, doing the laundry, gardening, usually small flexion movements because those are painful.
So if I get this right, the cycle that you're seeing is somebody hurts their back, maybe the back pain starts to go away and they start to feel better, but then because the multifidi has been shut down, so then the multifidi shuts down.
Yep.
From there, the multifidi is never actually rehabbed properly, and because it's not rehabbed properly, it stays offline, and then you go to chronic back pain, and now we have this chronic back pain. Is that correct?
That is exactly right. And you hope most patients will lie in bed for several days after the initial injury, and they'll recover. But what you described is the chronic cycle that happens, and those are our patients.
And so at that point where the person's gone through this cycle, what you're saying is you can go in and you can do this therapy. It's going to help to rehabilitate these multifidi muscles, and through that you'll go back to a state where you no longer have back pain. Is that correct?
That's exactly right.
Okay.
You interrupt that cycle.
So how exactly is that? Like, explain the procedure and how it works.
So the simplest way to think of this is every muscle in our body or any function in our body is driven through an electrical signal that's sent somewhere.
Yep.
We know that basic reality. We identify which nerve causes the multifidus muscle to fire. It's the medial branch of the dorsal ramus. It's the same nerve that you would target for radiofrequency ablation.
Yep.
There are sensory and motor fibers in that nerve. So we simply place electrical leads right next to that nerve. Doesn't have to be touching it, just has to be near it because there's lots of contacts we can program with.
Yep.
And you're just setting it up, and this is why it's neurostimulation, not neuromodulation, for what you said before. You're just setting it up so that an electrical signal can be picked up by the nerve. Electrical signal is picked up by the nerve, the muscle contracts.
So you're saying, again, the device, the Reactivate device, can send a signal, and when you push that signal out, it's essentially going to make that nerve fire. So it's kind of like a TENS unit, and if it was on your muscle, that electrical signal comes, you feel the muscle contract, and then it uncontracts. We're doing that same thing, but at a specific nerve level, and by doing that, of contract, relax, you're strengthening that muscle. Is that what it's doing?
You're actually, the strengthening of the muscle is secondary to reestablishing motor control of the muscle.
Okay, so you're starting to get that to fire again the way it's supposed to. How are you restoring that neural connection from the multifidi to the brain? Like, I can get how you're getting it to fire, but what is the connection back to the brain? What's the theory, or at least the science on that?
So it is part theory and part science, as with all neuromodulation. Repeated contraction of the muscle. So the way that the therapy is programmed, the contractions are 10 seconds on, 20 seconds off for a 30-minute period of time, twice a day. Patient activates it. And what we see is that the reestablishment occurs because we're able to measure that contractions of the muscle are happening automatically when the device is not on. We can see that for the first time through PET imaging. So we see it in the brain, you can pick up when glucose is being consumed in the muscle. And we have evidence now that glucose is being consumed in the muscle, meaning it's firing outside of stimulation sessions. So that's the science. How durable and when you reestablish that connection, is it permanent for the rest of the patient's life? We don't know yet. We do know about 10 or 15% of our patients are voluntarily having the device explanted after a period of time because they consider themselves cured. Obviously, with chronic low back pain, you carefully use the term cure.
Yes.
You injured yourself. You're likely to potentially injure yourself again. So we consider it a permanent implant. Not all patients look at it that way.
Okay. So with that, then let's talk about some of the timeline and stuff like that. Is this similar to physical therapy timelines, where you get injured, you go to physical therapy, you're maybe there for 3 to 6 months, and then your pain through that time period, at first it may be more painful while you're doing the physical therapy, and then it's less, and then you're feeling good, and then you're not healed, you're just feeling better, and then you get strengthening, and now you're able to go back to full function. Is that a similar process when you use the Reactivate, to where there is maybe increased sensitivity for a while as you're doing the strengthening, or what's a patient experience from when you start doing this through recovery?
So the algorithm of how much stimulation, how often in a given day or given week, a lot of that was taken from physical therapy literature early on. So in that sense, it's a question of how much muscle contractions do you want in a given day. So a couple things. One, the reason to stimulate the nerve instead of trying to stimulate the muscle directly is, as you know, with the TENS unit, you will just get certain fibers will fire, we get a physiologic contraction, right? Because we're stimulating the nerve. The patient experience is They start to use the therapy. Like I said, 30 minutes twice a day, typically at night and in the morning, because we ask the patients to be immobile when they do it.
Okay.
So it's just a contraction. You're not supplementing it on your own. And the data now is very clear. We're about 9 clinical studies in. The benefits start to accrue in the first 45 days, and it's typically function. Function returns first.
Okay.
Pain levels may stay the same. Patients often trade function for pain. So they're doing more, so the pain level's up. 3 months going to 6 months, you start to see pain come dramatically down while function continues to go up. Okay. So in that sense, there's a good comparison to physical therapy. In the early days, there isn't greater sensitivity generally, but patients get used to the contraction. It's a strange feeling. It's described almost universally by patients as it feels like a deep tissue massage. But it's weird because no one's touching me, right? So it's a long, smooth contraction. Almost all of our patients fall asleep with it on at night. They get very used to it. They get accustomed to it. It feels good. And then after they've used the therapy for a long time, they generally use it every single night because it's a comfortable thing, and it seems to relax them from the tension of the day. And then they decide whether to use it again in the morning for their second session.
Wow. So, I mean, that's a very normal thing for us to see in any type of pain management and pain care, which is like a person can come in and they're a 10 out of 10 in pain, but they're not doing anything. They have to sit on the couch, they can't go to work, they can't play with their kids, they can't do anything. You start working with them, you start to get that pain under control, and now they may be a 10 out of 10, but they no longer have to sit on the couch, they can do some other stuff, right? And so they start to move, they start to get more active. Now we see their pain start to come down, but they're getting more and more active, and they may even plateau. We'll see this where someone could be a 5 out of 10 in pain, but they're active, they're doing everything they want to, and they're happy in the fact that they couldn't do anything. They still have pain, but now they can do everything that they want to, even though there's still some pain. And so I love the fact that you bring out that there usually is a trade-off in pain and function, and the fact that most people will say, well, pain is something we want to avoid. Once you've lost function, it's a whole different level of motivation to get things back, right?
No question.
We have patients that they come in and they're like, I've had pain for 10 years. And we say, well, what brought you in today then?
Yeah.
And they're like, well, I was playing with my grandkids and my back hurt and I wasn't willing to give that up, so I decided I needed to take care of it. And so we have these different motivators when we lose function. So the fact that this is specifically designed to restore function, I think is something any doctor out there would be interested in hearing more about. So let's talk just for a second about indications, insurance coverage. I know that for doctors or for patients that may be listening to that'd be a really important question for them to understand. What's that look like?
So currently, this therapy is available in the Medicare population.
Okay.
We specifically worked with several of the regional MACs that do Medicare administration. Noridian on the West Coast most recently has a specific coding and billing policy specific to Reactivate. So there's clarity in the Medicare population. It's generally available to the VA population. It is spotty with respect to commercial availability for now. The biggest, the entire state of Alabama, for example, where Blue Cross Blue Shield has access to the therapy. Wow. And then, as with a lot of other devices, every private insurance company has approved cases and every private insurance company has denied cases. And we are actively working on that. We can get into the detail, but that's kind of the current state. And the company's been set up to run all the clinical studies, all the economic studies, to eventually drive this to a standard of care level with ubiquitous coverage around the country.
And what is the indication for this?
So indication is mechanical axial low back pain.
Yeah.
You have failed conservative treatment, so you failed physical therapy, medications generally.
Yeah.
And you don't have an indication for spine surgery.
Okay, so it's a non-surgical case,
Yep.
but you do have back pain and you've tried other things.
Yes.
Okay.
Yes.
So
Most importantly, physical therapy, to the earlier discussion.
Yeah, because if you can do it without direct, even if it is minimally invasive surgery, it's still something that if you could go to physical therapy and it was going to help, that would be the preference. But if you've done physical therapy and it hasn't helped, knowing that there's still hope and that there's something else that can be done,
Yes.
I mean, that's fantastic.
It's the best discussion that we have with physical therapists when we describe the patient state and all their signs of the disease state. We describe multifidus dysfunction, which Physical therapists know better than anyone
They're really good with it.
what that is. And then we say, but we only want to treat the patients that you have decided you really can't help anymore. They can't activate that muscle on their own, or they can't do it frequently enough, or it's so far gone that they need a jump start, essentially.
Okay. So with this then, I know you're working with physical therapists, different types of providers. Who's primarily doing this procedure? What type of doctor?
So it's split across interventional pain, both interventional anesthesia and interventional PM&R, and spine surgeons.
Gotcha.
And it's mainly because the patients sit in all of those clinics. These are the patients that no one has a good long-term solution for. They're likely to be in any of those clinics. I would say the physicians who seem to most quickly grasp the therapy and disease state are physical medicine.
Yeah, interesting. So the way that this was brought up to me when I first heard about your company, I was talking to one of my buddies who's the CEO of Bladder Centers of America. He was like, have you heard of this company? And we were talking about it, and we were specifically talking about how when you do MBBs and RFAs over and over and over again, so these patients that have, RFAs work for them, they're getting relief, but maybe 4 years go by, 5 years go by, and now they're not getting the same relief. And one of the theories on that is that when you do the RFAs over time, over and over again, you're actually, when you burn that, you said there's a motor component and a sensory component of the medial branch. And so as you begin to continue to ablate that nerve over and over again, you begin to see the motor nerve not activating that multifidus as much, and you get fatty infiltration. It becomes, in essence, it's becoming unhealthy. It's not doing its job, and that this is a great modality for those people that maybe their pain now isn't necessarily coming from the facet as much as it is coming from the multifidi, not stabilizing that whole area, and this can be a great therapy. Is that the right explanation for kind of how this came about, or how is that?
It's the right explanation for trying to understand who the patient is, because it's a similar diagnostic process. It came about initially simply by looking in the physiatry literature and seeing substantial fat infiltration into the multifidus correlated with low back pain.
And you can see it on MRI, right?
Yeah, you can see it. I mean, historically people haven't looked for it. And then you show it to someone for the first time, and it is right there in front of you, right? It is white, right? Because it shows up.
The white is fat.
The white is fat on the MRI versus dark, almost black, which is a healthy muscle full of blood.
Yep.
So, yeah, and now with all of the recent research and literature coming out showing that repeated RFA over time adds to fatty infiltration and connective tissue buildup in the muscle, it is absolutely the right thought process to think who's the patient.
So with that then, I mean, like for any providers that are wondering if they have these patients, so if they're deciding between doing another RFA, doing something like a peripheral nerve stimulator for the medial branch, or doing this type of procedure, one of the good indications for this may be look at your MRI. If you see a lot of fatty infiltration into the multifidi most likely needs to be rehabilitated. And this is specifically designed not for the pain component, but for that rehabilitation. And if you rehabilitate it, it's really treating the root cause of this, right? Rather than just covering up a pain signal, you're actually really working to make sure that the muscle's rehabbed. And if that's rehabbed, the hope is that the pain will go away, correct?
That is exactly the right way to think about it. In our big clinical studies, we tracked everything, and our patients had 3 to 4 comorbidities. 70% had advanced disc degeneration. A large portion had modic changes. 70-something% had facet arthropathy. So you see these other, classically we would say pain generators.
Yeah.
And the question is, do you treat the pain generators still, or do you try and treat the underlying cause? And the data from our studies would say in a properly selected patient, if you treat the underlying cause, many of those other pain generators resolve on their own.
So, I mean, that's the question I had, because we have all of these different wonderful new neuromodulation companies. Neuromodulation as a study, we're seeing new companies, new players come into that space, a lot of research happening there. But also when you look at the doctor side of it, it's almost like a new rep and a new group is approaching these reps every day of, you should use this product and this product. So for you and your company, what is the pitch to doctors of why should they pick this over, SCS or PNS or any other device that is treating low back pain?
So Reactivate doesn't obsolete any of these other therapies in someone's practice. It's all about patient selection. And I think that the most unfortunate term in our industry is chronic, non-specific low back pain. It's a death sentence of a diagnosis for a patient, because it means I don't know what to do with you. So I think the extra work has to be done into segment the patients. The easiest way to understand who's properly indicated for reactivate versus something else is, can you diagnose multifidus dysfunction? And that is your pain actually in your back versus radiating all the way down your legs?
Yep.
Do you see fatty infiltration on the MRI? That's a sign, it's not a diagnosis. And you do simple physical assessments, and you can literally assess a patient easily in a clinic room as to whether their multifidus is dysfunctional. If you have multifidus dysfunction, then treating pain generators one-off is not ultimately going to bring you to a point of recovery. You need to first treat the underlying cause. Because the fact that the muscle isn't firing is putting a lot of pressure on the facets, a lot of pressure on the discs, pressures on the end plates, and that's going to continue to deteriorate until you treat that cause. You may at some point need a future interventional treatment on a specific pain generator, which is why I say this doesn't displace other therapies in your practice. But you're doing a disservice, we believe, to the patient if you're not treating the underlying driver.
So I know I can just hear me talking to a patient about this and them asking this question, so I'm going to ask it. What if they've already received like an SCS or a PNS and stuff like that? Can they still get one of these procedures or not?
It's not contraindicated. You can still get one of these procedures. You'd have to figure out or decide clinically with the patient, is this taking the place of the existing device or is it in addition to? But there are patients who've had other devices, who have tried and failed other devices, who currently have another device, so it's possible.
Now, by the nature of what your device does it almost make it to where the patients don't need it after? I mean, in theory, if it's actually rehabilitating the muscle properly, you wouldn't need it after a certain amount of time. So how does that work if we're doing a permanent implant? Do they get it explanted? I know you talked about it briefly, but like, is the intent to have that be an actual permanent implant? Do they get it out explanted after a certain amount of time? What is the process for that?
It's a great question, because we do see such sustained relief with the therapy. I mean, we have the first device of its kind with published 5-year data. And the patients, to think about the recovery, patients get a lot of the benefit of the therapy by the end of year 1, but significant improvement between year 1 and year 2, and still some improvement from year 2 to year 3, and then it sort of flatlines and you maintain it. We've gone out to 5 years so far. And so patients ask this question all the time. I will tell you, when I first joined the company 7.5 years ago, I assumed that this was a temporary device. It looked like a lot of the benefit is delivered to the patient by 18 months. And I sat down with several patients early on, and I remember saying to them, so one of them had just run a marathon, which was amazing. You just ran a marathon, so it's time to have the device taken out, right? I honestly thought she was coming across the table at me, like, no one's ever taken this device out of me. So it'd been integrated into her life. And then you think clinically, if, about 2/3 of our patients are considered remitters, so statistically pain-free at 5 years, but the vast majority keep the device in. And they do it because they still use it prophylactically. Some use it in advance of what they know is a really busy week next week. We have a bunch of patients who are foremen on construction sites. They know they have a busy week. They'll use the device in advance of that. And so it seems to work into their life, with a minority of patients, like I said, about 10 or 15% opting to have it explanted permanently. And what we've seen thus far is those who've had it explanted have not needed to have a new device reimplanted. But that's a separate area of research we have to figure out.
Well, I mean, I look at this, and as somebody who studies biomechanics a lot, in today's world, we sit at desks, we sit with bad posture, right? Everybody, whenever I say that, everybody adjusts their posture, right? But I mean, it's the truth in the fact that we went from working in factories, in fields, moving, running, hunting, to sitting for the majority of our day. And when you're doing that, the multifidi is really healthy when it's engaged and active and we're moving. Right? And when you're not, and when you're sitting for long periods of time, it will either be, depending on how you sit, it could be under strain for long periods of time, which isn't healthy for muscle, or it could be in a state where it's not doing its job, where it's supposed to be passively stabilizing that area. In either of those cases, you can see that there's a reason we have chronic pain chronic low back pain as a almost epidemic. You probably could call it an epidemic in our country. And that if you were looking at what's one of the most important things we can do for people, it's really rehabilitating the core. And making sure that you have a stable core is going to stop you from having chronic back pain almost better than anything else. But this is essentially helping with that. With a specific muscle set in the multifidi, that's a really fascinating way of looking at that. But I know for people that are really active, you're saying that it's not just sedentary people. These are people running marathons. This is people that have back pain, can no longer do those things, and are using it to be active again. Is that right?
Yeah, I mean, what we're learning is we all know about strengthening our core in order to stave off back pain.
Yeah.
And typically what we see in our patients, the motivated ones, is they've done everything they can to strengthen their core. Their core muscles are taking the place of what the multifidus should be doing in stabilizing your lower back. And our patients oftentimes complain of exhaustion of other muscles. Many of them think they need a hip replacement, but it's their hip muscles that are overtaxed because the multifidi are not performing their function. And so, yeah, the worst thing you can do with the multifidus muscle is be inactive.
Yeah.
The amazing literature research here over the last 10 years has found, interestingly, almost every astronaut who comes back from outer space, low back pain.
Yep.
And they have finally answered the question why. And it is unloading of the spine has the same negative effect on the central nervous system driving the multifidus as an injury.
Wow.
And so we're seeing this as the primary cause for low back pain in astronauts returning. Like sedentary activity or lack of activity is essentially the same thing. They just have it.
The muscles aren't activating. If they're not activating, they
Exactly.
get sedentary. So what is the future then of this? I mean, we talked about how coverage is mostly based in Medicare.
Yep.
How do you expand that?
So we have taken the approach of evidence. We just produced a second 200 plus patient randomized controlled trial. We have about 8 real world studies. We have taken the approach that because this is a novel mechanism of action, insurance companies are going to want to see every single piece of it proven, all the way down to the basic research. And that has been our approach, is build the research compendium and put it in front of them. I believe where we sit today, we are on the cusp of lots of coverage starting to expand. We've gotten almost every insurance company in the United States to create a new category of therapy called restorative neurostimulation to separate it from classic neuromodulation.
Yeah.
We've gotten those who've written coverage policies to make clear you don't do a trial procedure because you're not testing for short-term pain relief.
Yeah.
So those things are all in place, and it's hard to predict when a private insurance company will write a coverage policy, but it's coming soon. The research continues to come behind it.
So does this have, I mean, the science can be true for other nerves as well and other parts of the body. What is the future outlook? Is this going to be the core focus? It solves a really important, very large problem, and the company's focus is only on this? Or do you guys expand into other spaces where it's similar in rehabilitating, restoring postural musculature?
Yeah, it's an important question for us. The answer is yes and yes, but total focus on the disease state of lumbar back pain with multifidus dysfunction for now. There's every reason to think the cervical spine has a similar mechanism of action that could be employed. This could be an adjunct to other types of procedures that are destructive in the body, and oftentimes other procedures that are destructive in the body ultimately don't work because the muscle doesn't rehabilitate quickly enough. You may have performed a great surgery, but the musculature doesn't come back. So there are lots of things we'll do in the future, but we are totally focused on low back pain.
I mean, it's a massive problem. So like you could
Yeah.
just like spend your whole career in the low back pain space and you'd help
Absolutely.
millions upon millions of people.
Yeah.
But I'm just curious because the theory of it and the science behind it, it sounds like it has additional applications. So how did you get into this? Like, what's your background? What led you to this space and made you passionate about this?
So I ended up serendipitously in back pain at all. I'm for what I do, it's bizarre. I went to law school, practiced corporate law for a while. I ended up with
Stanford, is that right?
I went to Stanford for law school. Yep. And I had a client that was a small spine implant company, and I ended up doing the public offering for that company.
Oh, that's cool.
And then helped them raise money as a small company, did their public offering, and then called the chairman CEO one day and said, I don't really like practicing law, so I'm going into work in some other company. He said, what are you doing for dinner tonight? And I ended up going to work there instead. And over 14 years, I did literally every role in the company. and eventually figured out at 38 years old that I was a sales and marketing person, but didn't know it early in my career. Because I went from legal in that company to regulatory, clinical, you name it, and then eventually product development, marketing, sales, and along. And I saw, like I mentioned earlier, I saw this therapy in the early stages of development, and I love the disruptive potential of certain technologies.
Yeah.
I want nothing to do with, this is personal view, I want nothing to do with pedicle screws, or I'm the wrong person to run a spinal cord stimulator company. I'm a market creator. It's hard. Insurance companies love to pay for things that are slightly better versions of what's already there. They hate to pay for things they don't understand, so you have to educate them. But I got here because it's an opportunity to help patients who, like almost 100% of our patients have been on opioids. This is the forgotten patient, and by the way, it's 65+% of all back pain.
Okay, so as the CEO of like a med tech company that has to create really this space, because I don't know of anybody else in this space, what are the biggest challenges that you face in trying to expand this and grow this company as the CEO?
So from this seat, I'd be disingenuous if I didn't say that money is always an issue.
Yeah.
Both the ability to raise the money. Medical device is not the sexiest place to invest if you're a big hedge fund or a big investment fund in the U.S. Drugs have proven and biotech has proven to be more lucrative for them. But device is just a longer scale investment. But we've proven to be able to do it. So raising the money is a big deal for us. And then making sure people are willing to pay for it. And now you're back to the reimbursement side. We've been fortunate. Last year, a little over a year ago, we raised well over $100 million. We're north of $300 million raised in the company. So we've spent a ton of money to try and figure this out. But research is really expensive.
Yeah.
You don't run a randomized clinical trial and have an insurance company pay for the device. By definition, they're not paying for the device. So these are expensive things to do. And if you want to create a market like this, it has to be evidence first, and you have to have a long view.
Yeah.
It's why I say that this company is not for sale.
Yeah.
We still have a lot of work to do. And I think the bigger companies wouldn't put that attention into it.
So like, it's a really unique space because you're trying to convince investors that it's worth doing it. But at the same time, you just said that you're competing for those dollars in the biotech and the pharma and everything like that. So what pitch do you make to them that says this is worth it? Because I believe that solving these problems at their root cause is one of the most important things that we can do. And it's one of the reasons I was really interested in this interview is it seems from a theory point of view, this is a really important technology. But what's the pitch that you make to these people that when they're looking, they're looking with their wallets and they have to open it to you and they're looking at what's the ROI I'm going to get here versus elsewhere? Like, what pitch do you make for that?
So the foundation of the pitch is I can give you confidence that I can forecast the point in time in which this will inflect. And it's such an investor word to say inflect, but like investor wants to know that they're okay if it takes a lot of capital to grow something. They're okay to invest in basic research. If they feel like they can forecast the point in time in which the adoption will happen, the insurance company will pay for it, patients will like it, and most importantly, physicians will understand it, know how to apply it, and demand it. That's the pitch. The pitch is, even if it's a long time out, I can tell you what has to be done before we get there. And that's really what it was. And I would tell you, it's still a minority of investors who will make this kind of a bet in a device company. Yeah. Investors throw money at biotech and pharma all the time, and they compete for those deals. It's not a lot of medical device investments where the investors are really competing, not as much. But at the core of the pitch is really about, I can tell you what has to happen before this, meaning market access will occur, and whether they trust that you actually know what you're talking about.
So how important is it to have other wins with like the payers in that process of raising capital, right? So obviously the clinical trials and the runway that you just talked about to get to that inflection point is long.
Yep.
And you just talked about how you had to go through multiple raises, and your last one was a $100 million raise. What are the things that allow you to go from like A to B and C, and to go through those different rounds to where it's like, if you don't have those things and you're not showing progress in certain areas, you're not even getting people at the table.
So I think by analogy, it's best. If we were launching a therapy that competes with an existing therapy, another spinal cord stimulator, no matter how good the technology is, you can get wins in your current market that investors want to see. And the reason is because you have market access, people will pay for it. So you can go out and prove physician adoption is real, patient outcomes are real, you can do those kinds of things. Without market access in the early days, and in the very early days, our average patient was 50 years old because we hadn't done research on older patients. So we were fortunate, but we needed to go outside the US. And we have proof cases because that's what investors want to see. Earlier days in Germany, particularly in Germany and in Australia. And we can demonstrate in those markets, even though our teams are smaller because there's only so much investment we can make, we can demonstrate that physician demand is there, patient outcomes are great. Physicians will use this as a primary therapy in their practice once they figure it out, not as a dabbling thing one-off. And so we can show the things that investors want to see, penetration, so to speak, into an account, that kind of thing. And that was, I think, necessary for us because without market access, it's just hard to do it in the US.
Last question on funding. How important is it to these investors when they're looking from a private equity perspective at a medtech company are the outcomes? We just talked about how important it is for adoption and for inflection and timing on ROI. How important is it on actual outcomes with patients, do you feel, in that process?
So it is, in my opinion, it's investor dependent. Some are much more financially motivated and they look at the financial outcome of how the business is doing as a proxy for what the clinical outcomes will be.
That makes sense.
And I think in a lot of therapies, it's fair to do that, and it's hard to assess the clinical outcomes. Our investor base is very different. Our investor base is incredibly focused on the clinical outcomes.
That's fantastic.
So much so that the brief story I'll give you is the $125 million we raised in this last round. It took 12 months. And the reason it took 12 months is because we had ongoing clinical studies, and we needed to be able to say to investors, this study is running, and here's how it's going to come out. Right? You don't know for sure, but you have to predict it. And the investors keep doing their work, and they wait. And finally, through the course of time, the study read out, and it was what we predicted it would be.
That's awesome.
And then they believe, I don't want to make it as simple as our investors believe that since the therapy works and the data is good, everything will just work out. But there is not a chance they were going to write a check without those outcomes.
I think with investors, one of the most important things is credibility, and that's what you just spoke to, right? You said, this is what's going to happen, and it happened. And when you can show that, it builds confidence from an investor perspective. Okay, this is the right person to lead this company. They're able to look at this process, look at what's going to happen, make the right predictions, because as a CEO, that's what we have to do, right? We have to look at the market and look at the chaos and be able to say, this is what's going to happen, and work towards it and accomplish it. And that's where I believe that if you're looking for funding, one of the most important things is this person credible? Can they do what they say? And are they going to actually lead us to where they're going? And so it's fantastic that you guys have been able to do that, because a lot of people don't. They make those commitments that this is what's going to happen, and it's more pie in the sky. That's what they want to happen, and that's very different than this is what's going to happen. And so sounds like what you are doing with the company, with patients and with these trials, is really being productive. And the reason I spent so much time on that is it is true, is that companies do not like to, PE does not like to back companies that are going to fail. Right? And to me, that's a great indication, the fact that you've been continuing to raise funds, continuing to sink money into research and development and to prove this out, is great for the patient and for doctors that may be interested in this, knowing that this is a therapy that's growing. It's growing in its research base. It's growing in its case studies. It's growing in all those things that really could be life-changing for people that are waiting for something like this to be more at the mass market. So how do you, and I know we touched on a little bit, but I want to say it again, how do you take this to the masses?
So the research focus that you just mentioned, actually caring about outcomes, using research to more deeply understand who your patient is, how to manage the patient. I mean, these are active implantable devices that you interact with as a patient all the time. Your interaction with them helps determine some of your outcome. how do you get physicians to understand it? Obviously, part of taking this to the masses is you have to have market access. So we have an entire strategy. We talked about that already, how we will ultimately have ubiquitous access to this therapy across the United States with all the private insurers. More importantly, it has to be in the mind of the physician of how they're treating their patient, how you select a patient, treat a patient. And our test case is to be able to sit with a physician and say, if you're an interventional pain physician, are you palliating chronic pain, or are you seeking to treat the underlying cause?
Yeah.
Do you really hope the patient does come back in a month or doesn't come back in a month? And of course, you go to medical school for a reason. You don't want your patient to come back in a month because they're better. But it's a longer term investment with a therapy like ours. Patient doesn't just feel better 3 days later. And so it's a long-winded answer to how do you take it to the masses? You help physicians understand that there's an investment needed. The patient's been in pain for 10 years. Are they willing to invest 3 to 6 months really focused on using the therapy? If they're not, they probably need a palliative treatment. And physicians have to assess that of their own patients. But ultimately, we think sharing patient stories helps people understand. They see someone like them. Our patients do get back to function before their pain reduces. If that's the mindset of your patient, you mentioned it before, if a patient still has a pain score of 5, for some people that's a home run if they're functioning. That's who our patient is.
So looking at that then, like knowing that that's the way to take it to the market and everything like that, one of the questions that I know, when I went to our doctors and I said, hey, Jason's coming from Mainstay Medical, do you guys have any questions and stuff like that? And one of the questions was, what does this look like for the patient after they get the procedure? Are they still coming in? Or how often are they coming in? Do they need to keep coming to the clinic? And then lastly, and I mean, if you can take them in this order, what's the effect on medication? So let's talk first, if you will, after you get this procedure, how often are they needing to come in and to be checked and to work with and everything like that from a doctor's perspective?
So put clinical studies aside because you have a regimen of when the patient needs to come back. So patient is implanted and then activated 2 weeks later. Classic neuromod approach to that. Following that, most patients in the first year of their therapy will have the settings of the stimulation adjusted, sometimes up, sometimes down. Sometimes they get used to the muscle contraction and they want it to be more intense. Sometimes the intensity of it builds as the muscle starts to become more active and it feels too strong and you can dial it back. It's really straightforward to do this. We are not modulating of waveforms. So you're not trying to tune in, so to speak, the waveform to match a pain signal to block it. So that regular process that happens with neuromodulation doesn't happen with our therapy.
Oh, that's cool.
Once your settings are good, you're good. And then the only reason you come back to the doctor is because the doctor wants to see you, they want to see your progress. Honestly, most of our physicians bring their patients back because they like to have successes in the office. One of our larger implanters says he loves to see the patients at 12 months because he feels like that's when they have this incredible benefit, but they usually don't show up for the 12-month appointment.
Yeah, because they don't need it.
Yeah.
So like, why spend the money if they don't want to go, right?
Yeah.
So the next question I think is equally important. What is the effect of like the Reactivate product on opioid utilization?
So we track, in every one of our clinical studies, we track medication use. The biggest study we did, we showed 70% of their patients either eliminate or meaningfully reduce their opioids, with about half of them coming off their opioids completely.
Wow.
So it's massive. And that population wasn't recruited for any motivation to get off their opioids. We didn't track or try to impact dependence or anything else. That was just voluntary reduction. So it's massive.
One of the questions that I ask almost every guest, I try to ask every guest, is how do we defeat the opioid epidemic? And it's something that's near and dear to our heart. It's something we work with every single day. We see patients that suffer from this, that they really do have immense pain. And that pain, I think, drives addiction, right? It's really, really hard to say you just need to treat this addiction, you shouldn't be addicted when they're having a 10 out of 10 pain. I think until you can solve their pain, you're not going to be able to solve their addiction. But in this sphere, like, I'd love to ask you this question. Knowing what you know about this technology and everything else about healthcare where you've been in your background, how do you feel like we as a industry, as a profession, as healthcare body in general, how do we solve the opioid epidemic?
So obviously this is complex. I've had some unique experiences in this. I've lived and worked outside the U.S. for a decent portion of my career. Lived in Europe. I've been in all the European medical systems, spent a lot of time in Australia, and none of the health systems are the same. The Australian health system is driven by physical therapy, like overwhelmingly by physical therapy.
Really?
And it's interesting because medication use is still high in Australia. Opioid use is much lower. And the assumptive process in empowering physical therapy is you have to engage for the longer term through your recovery process.
Yeah.
There's no short fix to things. That's a mindset issue. The European systems are much more about what we'd call CBT, cognitive behavioral therapy, understanding the mind-body connection to pain, how much of it's physical, how much of it's emotional, how much of it is a reaction to an underlying injury. And it unfortunately gets shorthanded as catastrophizing. It's not catastrophizing, it's trying to figure out that connection.
Yeah.
So where do you put all this, and how do we get away, how do we solve the opioid epidemic? I would say the explosion of really good research behind really good neuromodulation, neurostimulation therapies is a piece. Many of these therapies we believe are ours, but many of them should be indicated before you go on to chronic opioids, to see if you can avoid that. As we all know, once you're on opioids, it's really hard to get off if your dosage gets to a certain point. Quality physical therapy, unfortunately, is not standardized. I can tell you, our average patients had 33 sessions of physical therapy. They've tried physical therapy. I can't tell you what was done in those sessions, or if it was standardized, or if the program was attached to trying to regain motor control. So I think it's all of these things, but as a default, I think we have to hold the prescription and try other things.
I like that as a process, and I actually hadn't even thought about that as it pertained to your technology, in the fact that the patient that I had in mind was a chronic pain patient that's come in and they've tried everything. They may be on opioids and all sorts of other medications. They've tried MBBs, they've tried RFAs, they've tried epidurals, they've tried physical therapy, and now we're saying, okay, here's our last chance type of a thing. But what you're saying is that actually, ideally, this would be implemented a lot earlier, in the fact that yes, they've tried conservative care, they've tried physical therapy, they don't need surgery. This is a great time to try that instead of necessarily putting them on increasing dosages of medication.
The data in our clinical studies completely supports that conclusion. 40% of the patients in our clinical study were on opioids when they came into the study, but almost 100% had been on opioids. Which patient is the properly indicated one? The one who's maybe tried opioids but cycled off. It usually speaks to motivation, or patient-physician relationship is really strong and they listen to their doctor. It didn't work, so you get off. That's a great candidate. At the same time, not all the patients in our clinical studies, almost half, have never had an interventional therapy. This therapy, this is the reason why education is so important for us. Neuromodulation is generally an end-stage therapy. You've tried everything else, try neuromodulation. This is not neuromodulation.
It's neurostim.
It's neurostim. It is a functional treatment, a rehabilitative treatment. It should be indicated for the proper patient much earlier, before all of those other things. Though I will tell you, many physicians go through all of our education process, and then their first patient is an end-stage patient. And they say, I get it. And then they watch the patient, and then the light bulb goes off and they realize that's not the right patient. It's much earlier in the disease cascade when I can still help them. Right? Because at that point, you're trying to palliate no matter what therapy you're using.
Yeah, and I like the other part of your answer on the opioid epidemic, which is we're treating the root cause, right? As long as you're treating the root cause on stuff, whether that's physical therapy, whether that's chiropractic, whether that's neurostimulation, where you're actually rehabilitating the musculature, that if you can actually treat the root cause, symptoms go away. If symptoms go away, you solve a lot of the opioid epidemic.
If I tear my ACL and I go to the orthopedic surgeon, I'm not going to the orthopedic surgeon with the chief complaint of pain. Yeah, it hurts. But the orthopedic surgeon goes in and they fix my ACL. They hope I feel better as a result, but they're not treating pain primarily. That's the closer analogy, I think, to the way this therapy works.
I think it's a really good way to look at the therapy. I know, like for me, just because we do so much neuromodulation, like I was thinking of it as an end-stage therapy.
Yep,
I was
yep.
like, okay, like, and where does this differentiate? And maybe that's a much easier way for doctors to differentiate if they're trying to choose between the question I asked you earlier: do I do SCS? Do I do PNS? Do I do this reactivate?
Yep.
And the answer is, well, if it's early on in the stage and you know that you have this fatty infiltration of the multifidi and you're seeing that on MRI and you haven't tried those things, maybe it's a better therapy earlier. And guess what? If that doesn't work and we continue to progress, you still have those other neuromodulation cases to be able to default back to as well.
I think you're absolutely right. If you're choosing between SCS, PNS, then it's probably not a reactivate patient.
Yeah, it's too late.
Yeah.
Okay. Now, I know we didn't talk about this yet, but what is the percent success rate of this type of modality?
So across now 9 clinical studies, the success rate is roughly 80 to 85%. We have about 12, 13% patients inadequately or don't respond to the therapy. About 67 to 70% of the patients are considered remitters, so their pain score is below 2.5.
Okay, wow.
And then a few patients that fall sort of clinically significantly improved in that small gap between 70 and 85%.
This across 5 different studies, but how many people is that across
So we
all
have
those studies?
1,800 years of follow-up on 600 patients in those studies.
1,800 years?
So on average, we have 3 years of follow-up for every patient.
For everyone, okay. Yeah.
So my point is they're long-term studies.
Gotcha.
We have 5 other studies that are shorter because they're just going. This is the one therapy where you'll see as often as possible the patients will be followed for as long as possible.
And you feel like the data gets better actually the longer it goes?
Yes.
Wow.
Unequivocally, the longer you use the therapy, the better you do. And as we know, unfortunately, with other neuromodulation therapies, it's usually the opposite.
The opposite, yeah. And I think that's another really big differentiator, though, is that neuromodulation has somewhat of a reputation of, it is an end-stage therapy. We're doing it specifically to try to be able to say, how do we help to control and manage your pain, but from a non-medication point of view, and how are we helping you to give your life back and be active? But what we see over time is where you get what's called, neural adaptation. You begin to, that signal that you're blocking, your body adapts.
Yep.
And as it adapts, it may not be as effective. And they can go in and tweak that and change the wavelength, and they can change the modality. But it is something that you're having to deal with. Whereas this one, because you're treating that root cause, it should get better and better and better instead of this accommodation where it drops off. So
Yep.
that's a really cool place to be in. So for you, as the CEO of Mainstay, what is your greatest objective over the next 3 and 5 years of where you specifically see this going?
So our overriding goal right now is to continue to prove that we get the same clinical results in the real world that we got in our clinical studies. I believe that this is the rare therapy where the average clinician in their clinic can replicate the clinical results in the study. That's not always the case in our world, as we all know, but
Yes.
we are now about to publish, I would say, our 5th real-world study. We have a bunch of smaller ones, but our 5th, and we'll be at 10 real-world studies published here by the end of the year or the beginning of next year.
That's fantastic.
People are going to continue to see the results. I mean, we have a chart that we love to show where we track pain reduction over time. And if you just sort of follow this line from lots of pain down to out 5 years, you have average patient, like I said, as statistically almost no pain. The 3 clinical studies that were organized are all on there. The others that we lay on are real-world studies, and they follow the exact same curve. You're getting the same results. That is our overriding goal. Our view is, if we can prove that, then clinicians have confidence to adopt therapy into their practice.
Yeah.
And this is not the therapy you dabble with, so to speak. Oh, and maybe once in a while I see these patients. It's either a primary therapy because you believe in addressing underlying cause, or you address pain generators. And neuromodulation is a great therapy for a lot of patients.
Yeah.
It's just that's not our patients.
So you talked about adoption by medical doctors. Where would you say you're in the adoption curve? For people thinking about that adoption curve, right?
Yep.
We have the early adopters, you've got the early majority, the majority, the late majority. Where would you say you're in that process right now?
I would say we're from pioneer stage, which I consider pre-early adopter, into early adopters. I'd say we're deep in the early adopter phase.
Okay.
And I can see that the education we're putting into the market, which is just basic education about the disease state, who the patient is, where they should be indicated, is out there. Awareness is rising quickly. We haven't gotten out of the early adopter stage into the early mid.
And what do you feel like is the biggest hurdle to crossing that threshold?
Access.
Yeah.
When we train physicians, it's amazing. We follow the same pattern all the time, and we do it. We do the classroom session, we do the cadaver lab, and we go through it, and we have a debrief session. Fully 50% of the conversation in the debrief session is about access.
Because they're at that point in time, they're like, this is awesome.
Yes.
They're ready to go,
Yep.
but my patients don't qualify.
And they know they're going to go home. They have found before coming, they have found 5 well-indicated patients for whom they do have coverage.
Yeah.
Maybe it's a properly indicated Medicare patient, maybe it's a VA patient, however we do this. But they're going to go home and manage their patients, and they're worried about expectation setting. They want to say to a patient, you know what, Mrs. Jones, you've been coming to my clinic for 5 years. There may actually be a therapy that can solve your underlying issue or really address your underlying issue. I just don't know if your insurance company is going to pay for it.
Yeah, that's a hard conversation.
It's a hard conversation. Yeah. And we do all the work. We have a whole team internally who will do it, but it's still expectation management.
Yeah.
And that's your patient you're caring for. And so what we see is as more clinical experience is gained by the physician and they see the great outcomes, they're more willing to manage their patient expectations.
Well, it's part of that credibility thing that we were talking about, even with investors, right? When you go to your doctor and your doctor's like, I have something that's going to help you.
Yep.
And I'm really excited about
Yep.
it. And then, oh, you know what? Your insurance doesn't cover it.
Yep.
It's like, well, why did you bring it up, right? And
Yes.
it's the doctors are obviously extremely well intended. They're trying to help their patients, and there's thousands of insurance plans, and we don't know what's covered by every plan. So when we talk about a therapy, it's oftentimes because something has to be pre-auth first, and we don't know. But at the same time, I think that companies like yours that are making huge strides in improving care, we need to find ways to be able to get insurance to be able to cover it in ways that allow patients to try these therapies that are going to decrease opioid utilization, improve outcomes, treat the root cause, get people back to activity. Because I think when we do these types of therapies, it lowers the cost of care for insurance companies dramatically, and that's one of the most important things you need to prove out to insurance companies, is that the cost of the product is worth it to them financially, not just in patients being happy and getting relief, but does it translate to real dollars and cents for
Yep.
for the payers?
You're absolutely right. You actually said, you made the comment to me before that as a CEO, a big part of the job is the ability to tell people what's going to happen,
Yeah.
and then have it come true. And there's no doubt that's true. I think that's essentially what I do for a living.
Mm-hmm.
But it's even more true for a doctor.
Yeah.
Doctor sits with a patient, and what do? You tell your patient what's going to happen. Either if you don't treat it, or if we do treat it, how's that going to go? And
Absolutely.
we have to do the same thing with the insurance company. We've been sitting with insurance companies. I do every single insurance company meeting myself, and I've been doing it for the last 3 years. And their job is to tell them what's going to happen if they allow access to this therapy. And we got to bring the evidence to prove to them that's actually what's happening.
Absolutely. It reminds me of one of my favorite phrases is one of the main reasons for disappointment is unfulfilled expectations.
Mm-hmm.
And I truly believe that whether that's with patients, whether that's with payers, whether that's with investors, like you can take it across the board.
No
of
question.
Unfulfilled expectations is the main reason for disappointment. And so, our job as physicians is to make sure that when we go talk to our patients, we have real things that are going to help them, that they qualify for, that's going to provide that. And you have to have confidence in the therapy. And the type of numbers that you talked about, we can have confidence. If something's 20% effective, it's really hard to have those conversations.
No question.
If someone's 80+% effective, you can go in there and say, I'm relatively confident that we're going to get good outcomes. This is going to help you. So it sounds like you guys are like really fighting the good fight. You're pushing this technology forward. I'm really excited to hear about it. So I thank you for your time coming
Thank
in,
you.
talking to us about it, and really do wish you the best as you continue to grow this company and push it forward.
Thanks for having me.
Absolutely. Thanks for
Appreciate
coming
it.
on.
For sure.